So I wanted to start just by asking what is neuropsychology, and many of you in the room may know only too well, but basically it's an applied science concerned with the behavioral expression of brain function. And in the context of Alzheimer's disease and other forms of progressive neurodegenerative disease, it's used as a diagnostic aid, so to help the neurologist come to a conclusion about what might be going on. It's also a useful baseline to evaluate treatments and also the progression of the disease, and it can be useful in guiding very specific questions such as competency decisions, should this person be making their own decisions about where they're going to live, whether or not they're going to drive, things like that, as well as assisting in making interventions that are appropriate for that patient. So as we all know, Alzheimer's disease is a progressive neurodegenerative disorder, and it starts in the limbic regions, in the central regions of the brain, which are responsible for episodic memory, so learning new information. This is reflected in the earliest neurofibrillary changes, which occur in the hippocampus and also the adjacent entorhinal regions. The disease progresses to the association cortices of the brain, and other cognitive domains become involved as the disease progresses. This cascade of neuropsychological impairment tracks the regional impairment in the brain. So one patient might have more of the posterior sort of visuospatial impairment secondary to memory. Another patient might have a more executive profile after their initial memory loss. Studies of memory in AD show that the memory loss is cross-modal. So in the clinic, we'll use paper and pencil tests to look at nonverbal or visuospatial memory. Can someone learn a series of designs and recall those later? We'll also use auditory memory, so we'll read stories to people and test them using lists of words. And in the lab, people have used really cool studies to look at olfaction. And in all these different cross-modal cases, the pattern of learning and memory decline is very consistent, so it's cross-modal. So to explain a little bit about one of the most useful tools for neuropsychologists, I'm going to give you a little mini memory test. So one of the things that we do a lot is read people lists of words. So this is a very abbreviated one for you. So say we gave someone 4 words, such as lemon, beard, telephone, and daisy. We'd then ask them to recall it without showing it to them, of course. And then we might do that again and again. And then we would provide them with some distraction, normally other tests. We might look at their visuospatial function. And following that, we might spring on them by surprise. What were those words we tried to have you learn half an hour ago? It doesn't make us very popular. Later on, we might show them a longer list of words and say, which of these words was on that list that I showed you earlier? So from that, we garner a lot of information. We know about their learning, their recall, and also their recognition ability. So in AD, what we see is an impairment in the free recall. So after they've had an opportunity to learn those words, maybe they learned 3 out of the 4 words, but after half an hour, they can't tell us any. So they can't recall the words. But unlike patients with something like a vascular dementia, they might not also benefit from the recognition test, picking out the words from a list. This tells us that in AD, there's an impaired consolidation as opposed to an ineffective retrieval. So they learned those words very briefly, but it didn't stick in their memory. It escaped quite quickly with the distraction. This free recall and recognition impairment is further impacted by an increased sensitivity to interference. So we're distracting them with other tasks in between, and they're losing the words. Similarly, on the recognition trial, they might not have that certainty. Was telephone on that list? Was Daisy on that list? Most of us would have a sense of familiarity. We saw one of those words before and not the other one, but someone with AD might lose that sense of familiarity. Something else that neuropsychology can tell us is that for most of us, we use semantic clustering when we're trying to remember something. So if we have a mental list when we go to the supermarket, we might remember that we need 2 cleaning products, we need 3 or 4 different things to make a cake. When we get to the supermarket, we cue ourselves. We knew we needed to make the cake, and we've got the eggs and the flour and the sugar, but what was that one other thing? Well, it was a carrot cake, so it's carrots. But someone with neuropsychology, with Alzheimer's disease, might lose that cueing ability. So what do we do with the neuropsychological evaluation? One of the first things we do in terms of the testing is to look at the premorbid IQ. So what level was that person functioning at before? Were they I think, as Dr. Pillai mentioned, a journalist functioning at a very, very high level? Or were they someone who was unemployed for many years and maybe had struggled at school and maybe had some intellectual problems to start with? What our expectations of those two different people are going to be quite different. We'll then look at their memory, their speed of processing, their ability to pay attention to things, their ability to come up with words in conversation and also to understand what's said to them, their visuospatial functioning, and their executive functioning. So by executive functioning, it's a large category that covers reasoning, multitasking, switching set, many other things. As neuropsychologists, it's very important for us to appreciate the hierarchical nature of these domains. So if somebody has impaired attention or a very, very slow speed of processing, they're probably not going to be able to learn as many words as somebody who is intact in those domains. So we have to adjust our expectations depending on that person's ability to pay attention, to understand what's said to them, to bring out the words after the delay. Is it a language problem or really a recall problem? So because of these mitigating factors, the fact that these diseases don't affect just one domain, we really need to have a flexible approach in the way we approach our patients and interpret their results. So some of the assessment tools that we use as neuropsychologists involve a clinical history, and in many cases this will be the most important part of our assessment. So here at the Ruvo Center, we'll interview the patient along with their caregiver, spouse, or adult child. Sometimes we'll separate the patient and the caregiver so that we can get the two sides of the story. As has been alluded to, sometimes patients with Alzheimer's disease have reduced insight. They might think that they're just fine and their husband's absolutely crazy for suggesting that they have a memory problem, in which case interviewing the two people together might be more of a domestic issue than if we separate them and keep the peace. So sometimes we do that. Standardized tests available commercially, these would be the great majority of the tests that we use are tests that we buy and that have been very, very well normed. So we have a huge amount of normative data based on the collection of hundreds and hundreds of people from different parts of the country, different age groups, so we can tell whether or not this 85-year-old who remembered 3 out of those 4 words is doing as we would expect for someone her age, or is she doing worse, better? We can gauge whether or not they're doing okay. So we get that objective comparison, which is really core to our assessment. There are also many freely available tests of cognition and questionnaires out there, and we certainly supplement our assessment with those. And the non-standardized aspects of testing, which are particularly important, might be at the end of the assessment, do they remember my name? Is this person who's saying that they have terrible memory, are they able to tell me that they saw Dr. Leger next week and he told them that they had this, this, and this, and gave them these medications that they take 3 times a day, and thank you very much, Dr. Banks, it's been lovely to meet you. That information is, of course, important. It sounds like they have a pretty good memory. Do they evidence fluctuation during the assessment? Are they on 1 minute and off the other one? Are they showing a really scattered profile of tests? And also, are they able to remember the way back to the waiting room at the end of the assessment? We usually guide people, but we can watch them as they go. So here at the Center for Brain Health, we've developed 2 core test batteries that we use depending on whether or not somebody has a MoCA of less than 25 or 25 or higher. So the MoCA is a test that Dr. Bernick mentioned earlier. It's similar to the MMSE. We use those as our core batteries, but in specific cases we'll add on. So we see a lot of patients here who do have different aphasia syndromes. In that case, it's very important for us to assess thoroughly their ability to repeat, their comprehension, their ability to come up with different words in different contexts. So, of course, we'll add aphasia testing and effort tests. So very, very occasionally we'll get a patient who for some reason might be faking bad, they might be malingering, or they might be exaggerating their symptoms, in which case we have specific tests that we can use to try and get at that. Overall, we try to keep our testing time to a maximum of 2 hours. This is quite unusual in neuropsychology. A lot of my colleagues across the country will do 5-6 hour batteries, but really we want to get a streamlined assessment and get as much information as we can when the patient's still awake and functioning, and we'll add on if we need to, but generally we can get what we need to in 2 hours. So these are the tests that we do, and I won't go through them in detail because it'll be very boring for most people, but just to say that the green bit in the middle is the test that we do with everyone. So we cover the different domains that I discussed earlier. The tests in yellow are the ones that we do in the lower functioning people, so a slightly easier wordless task is the main difference. And the higher functioning ones get the Hopkins Verbal Learning Test and also a Tower of London type test, which is really quite kind of challenging. So neuropsychologists, by definition, are not robots. We have to use our brains a little bit when we're interpreting the test data. We have to choose the appropriate normative data to look at the objective evaluation. And that's important because test performance definitely differs by age, and depending on the test, it may also differ by cultural background and also by educational level. So to give you an illustration of this, I had a patient fairly recently who was an African-American man who had grown up in Mississippi. He had 12 years of education, he'd gone through high school, he was a smart guy, he'd lived most of his life in Chicago. And he got a 26 out of 60 on the Boston naming test. So this is a test where we show people pictures. Some of them are everyday objects, and some of them are sort of rarer things like accordions and abacuses. If we used our regular normative data set with him, he would show an impairment. That's much less than we would expect for the Mayo Older Adult Normative data set, which is a huge data set, but it was collected mostly in the Northeast, mostly with Caucasian patients, or Caucasian individuals. If we use the Mayo Older Adult African American normative data set, he was low average. And that's because, for whatever reason, the education that he had in Mississippi in the South, he was in his 80s, so it was a long time ago, was quite different from his peers in the Northeast, who were Caucasian. Sometimes this kind of normative data is certainly not enough. For example, you'll hear a little bit more about frontotemporal dementia later, which Dr. Cummins mentioned as something that I'm particularly interested in too. These patients, sometimes they just don't care about testing. Apathy is one of the central concepts of their disease, and as is a lack of insight. So getting really good effort out of them can be challenging. So if that person only is able to learn a few words and their normative data would suggest that that's an impairment, but they're able to retain those words over time, following that distraction, they can still tell us that they learned a telephone, beard, and lemon, or whatever it was, then that proof of retention is perhaps more important than the actual score that they got. So we look at the patterns a lot. Also, the nature of a naming difficulty might be important. Is somebody not able to name something because they don't know the word, they've never seen that thing before, or as a visual agnosia, they don't recognize it for a visuospatial problem. So we've heard a lot about MCI/prodromal AD today, and as you all know, many of the longitudinal studies will show that people who eventually go on to get AD had some kind of measurable memory loss fairly early on. So if that's one important part where neuropsychologists come in, we can come in and do tests and see, is this person's memory normal for their age, their education level, or is it a little bit impaired? So this is one of the products of our assessment. This table, I'll use my pointer for this, shows the range of level of functioning along here. So anything really above this heavy line and that's white would be normal, generally within the normal range. The estimated IQ, which comes first for this guy, this was a judge who we saw recently. He had a superior level of IQ, so our expectations for him are pretty high. On a learning test, if he has two little X's, it means that we did two different tests and he performed differently on those two tests. So here he did okay in one of the tests, but really not okay in another one. His recall is consistently below the normal level, and similarly, he didn't gain anything from recognition, so he wasn't able to pull out any of that information with cues. His attention, his speed of processing, the majority of his executive functioning, his language, and his visuospatial abilities were all well within the normal level. They might have been a decline for him because he's a really smart guy, but they were still normal overall. So that just shows you the very typical profile for Alzheimer's disease. So as the disease progresses, as I mentioned earlier, it goes into those association cortices and other domains become involved. So the exact trajectory of any one person's disease is very hard to predict, but often the secondary problems will be language or semantic knowledge, executive function, working memory or attention, and also deficits in visuospatial abilities if the disease progresses to more posterior regions. Generally relatively protected are some of these task performances that we assess. So digit span forward, the ability to quickly learn a series of 5 numbers and repeat it immediately. Vocabulary, so there are some pieces of information that even if you have Alzheimer's disease, they're relatively protected, and they just tend to increase as we get older. So vocab would be one, information, trivia, the kind of data that we just collect throughout our lifestyles, and thankfully some of it stays in there. Comprehension, the ability to comprehend what's said to us, and in parentheses there are similarities, so verbal reasoning, and that's something that in many cases will be intact and in others is not. This decline in cognition does coincide with a decline in activities of daily living, and we also do assess for neuropsychiatric symptoms. So again, as you've heard a lot of today already, depression, anxiety, irritability, these are very, very common, even in, and I don't know if it actually precedes the cognitive decline in Alzheimer's disease. So we've spoken a little bit now about the very typical form of memory loss in Alzheimer's disease, but there are atypical presentations, so this is where it becomes more fun for someone like me. So we'll get posterior cortical atrophy, which is atrophy that affects the posterior regions of the brain primarily, and usually the pathology there will be AD, but it can be other things. And obviously what we see in a patient who presents with posterior cortical atrophy will be quite different from typical Alzheimer's disease. There'll be a lot more visuospatial impairment and attentional impairment. Primary progressive aphasia is a disease which has heterogeneous pathology. It can be caused by various different things, but in some variants specifically, such as the logopenic variant, which is really just characterized by problems coming up with the right word in conversation, having very sparse words in conversation, that tends to be Alzheimer's disease. But unlike typical Alzheimer's disease, which affects the medial temporal lobes primarily, PPA will affect the left hemisphere or the dominant hemisphere in that person primarily, and it'll affect their perisylvian region, so their language areas before spreading, usually frontally. There's also the frontal variant of AD, which starts out with problems with executive functioning, so multitasking and that kind of thing, as well as behavioral change, often behavioral change such as disinhibition. And then there's a few case studies of a Kluver-Bucy phenotype, so hyperorality, hypersexuality, again, are the different manifestation in the brain of where Alzheimer's attacks first. Another one of our jobs as neuropsychologists is to exclude mimics. So this, I think, is some kind of a leaf insect. I was going to say a stick insect, but it's a leaf. But in Alzheimer's disease, there are a lot of things that come in where people will say my memory is bad or my mom's memory is bad. But what memory means for different people has a lot of diversity. So we might find if we probe further and if we look at the exact profile of their memory loss, that it's more consistent with depression or sleep deprivation. We have a lot of patients here, it seems, with sleep apnea, and also normal pressure hydrocephalus, and as we mentioned earlier, it's quite rare, but it can produce memory impairments or things that are described as memory impairments, but it tends to be more of an attentional problem, an executive function problem, and we can normally demonstrate in these patients that if they can learn information, if we can drill information into them, they will retain it over some time. So another non-Alzheimer's dementia is Lewy body dementia, and I believe you'll be hearing from this earlier in Dr. Walsh's talk. So this is traditionally considered to be a subcortical dementia. It's characterized by Parkinsonism, hallucinations, and fluctuating cognition. The hallucinations are said to not be scary for the most part, but this is an illustration by an artist who had Lewy body, and I find it quite hideous, so I would find that scary if I saw that. The neuropsychological deficits that people with Lewy body tend to get are visuospatial primarily, as well as executive. So this is one of the visuospatial tasks that we use predominantly in clinic. It's the block design task. So we'll ask a patient to use these blocks, which are all the same, to create these complex patterns. There's also some executive component as the patterns get more complex. They also have attentional loss, and the memory deficit that they show, and they often do show a memory deficit, but it's comparatively less severe than we would see in Alzheimer's disease. And it's characterized by more of a learning deficit, and their recall and recognition especially, will be much better than in AD. Another common form of dementia is a vascular dementia. which is caused by a cumulative decline in cognitive function due to multiple infarctions, ischemic injury, or hemorrhagic lesions. Because this can attack the brain in any different format, depending on where exactly the lesions are, will determine what the neuropsychology looks like. But typically, we'll see a sort of subcortical profile where we'll see executive functions. If it attacks the posterior regions more strongly, we'll see a visuoconstructional impairment. And we generally see some sparing of aspects of language, for sure, and memory, too. The frontotemporal dementias can be categorized into subtypes, so more behaviorally predominant subtype and a more language predominant subtype. So memory is always spared in the early stages. It can be very difficult in the language subtypes to determine exactly what they can remember if we have to get through a language barrier. And in the behavioral variant, because they may not care or they may be too busy worrying about what your earrings look like, it can be very difficult to assess their memory. So this is maybe a little bit controversial, but I wanted to talk a little bit about what neuropsychology means in the time of biomarkers. And some people would consider neuropsychology to be a biomarker, but we won't go into that. Certainly there are all of these exciting neuroimaging and CSF biomarkers out there. And what does that mean for neuropsychology, which is more of a traditional, old school part of the assessment? Well, one thing, and I think Dr. Cummings alluded to this with some of his discussion of the limitations of some of these biomarkers, especially the neuroimaging biomarkers and the CSF biomarkers, is that in the case of the CSF biomarkers, they don't indicate the topography of the disease. We don't know which parts of the brain are being affected by the pathology based on the CSF measures. It's also hard to know what the disease risk and trajectory is. So if somebody comes in and they have a positive finding on one of the scans, what does that mean? If they don't have any cognitive impairment, are they going to be cognitively impaired in 5 years? Are they going to be cognitively impaired in 30 years? If they're 80 years old, how much information are we giving them by saying that you have a positive scan? Of course, they'll have questions about when this will start to affect them. Certainly, many of these patients are not clean cases. They'll have comorbidities, and often patients will come in with 2 of the different diseases at once, so they might have AD and Lewy body. So which one is the primary disease in this case? Cognitive testing is actually required by the FDA as an outcome measure in clinical trial for new medications for dementia. And certainly the CSF biomarkers, and I believe also to some extent the neuroimaging biomarkers, really vary in their validity and reliability with age. So once you get over 80 or 85, having a positive finding on one of those may or may not be that useful. So neuropsychological testing and some of the structural imaging, the quantitative analysis of hippocampal volume, for example, might not lose its diagnostic value so much with age. So one use of biomarkers, or one use of neuropsychology and biomarkers, might be to try to ascertain which MCI patients are going to convert or progress to a dementia. So this study was recently published in Neurology, and it looked at cognitive testing as well as a whole bunch of different biomarkers. The cognitive testing, in this case a word list, a little bit longer than the one I gave you earlier, remained the strongest predictor in isolation. And it was actually the best predictor of conversion from MCI in AD when it was combined with that volumetric measurement. So taking a multifaceted or multi-pronged approach seems to be the way to get the most out of all this data. So amyloid, and I alluded to this on the previous slide, but if somebody comes in and they have a CSF test for amyloid but they don't show any cognitive change, will that person actually develop dementia? Maybe they should have some neuropsychology so we can track them over time. And in the absence of amyloid pathology, that doesn't necessarily imply a benign course. That doesn't mean that they're home free. So just to summarize what I've been through today, in the neuropathological change in Alzheimer's disease has an affiliation primarily for the areas that are involved in episodic memory, so learning new information. Consolidation is affected first. Other cognitive domains decline as the disease progresses into those association areas. Neuropsychology can be useful in diagnosis, in tracking change, and also in treatment planning. The interpretation that we as neuropsychologists do of the data combines the normative data, so the objective component, with a subjective component, the qualitative assessment, and also an understanding of the mitigating factors that go into the results. And neuropsychology continues to be a sensitive measure which stands alone or combines with the other biomarkers. So thank you very much.